Chapter 69. The Physiology of Cerebrospinal Fluid and Intracranial Pressure. This presentation will briefly review the concepts contained within this chapter, and the interested reader is referred to the text for additional and more detailed information. This presentation will consider the physiology of cerebrospinal fluid and intracranial pressure. It will also consider both steady state and non-steady state dynamics of intracranial pressure in health and disease. And this will be used as a framework to examine current therapies for raised intracranial pressure within this context. Cerebrospinal fluid is an ultrafiltrate of plasma modified by an energy-dependent secretion process. The mean adult volume of cerebrospinal fluid is 164 mL, with a range of 62 to 267 mL. The production of CSF is mainly from the choroid plexus and ventricular ependymal cells. The rate of production is 0.35 to 0.37 mL per minute. Absorption of CSF occurs mainly into the dural venous sinuses through arachnoid granulations. There are also lesser pathways of absorption through both nasal and meningeal lymphatics and the choroid plexus itself. Intracranial pressure depends upon the volume of tissue and fluid within the closed cranial vault. In the healthy state, this consists of the volume of blood, cerebrospinal fluid, and brain tissue. The volume of CSF is related to a balance between CSF formation, the volume of storage or compliance, and CSF absorption. Blood volume is regulated in relation to tissue metabolic needs by a process of autoregulation, and brain volume is largely regulated by its water content, and in the case of pathology, by edema formation. When measuring the intracranial pressure, an intracranial pressure waveform can be defined, and this waveform is dependent upon both cardiac and respiratory activity. The mean normal range of intracranial pressure is 5 to 15 millimeters of mercury. When non-steady state dynamics are examined, the Monroe-Keeley doctrine states that in order to maintain intracranial pressure, the addition of more volume, such as edema, hematoma, or hyperemia, must occur with the reduction of another volume within the cranial vault. This is a process of compensation. When the process of compensation is exceeded, however, at this time the intracranial pressure will increase. This slide shows example graphics of changes in intracranial pressure with relative changes of intracranial volume. On the left side, changes in intracranial pressure is shown directly related to changes in intracranial volume, and it can be seen that at smaller changes of intracranial volume, there are relatively smaller changes in intracranial pressure. And in this setting, the compliance of the intracranial vault is thought to be higher. However, towards the right side of the curve, as larger changes in intracranial volume occur, it can be seen that relatively larger changes in intracranial pressure occur, and in this setting, the compliance of the intracranial vault is thought of as being low. When a graph is drawn of the logarithmic change in intracranial pressure as compared with changes in intracranial volume, as shown on the right side of the slide here, a linear relationship can be seen. And the gradient of this line is defined as the pressure-volume index. The pressure-volume index is defined as the volume in mils needed to raise the intracranial pressure by a factor of 10. And therefore, by definition, the pressure volume index depends upon both elastance and compliance. When we think about causes of raised intracranial pressure in pathologic states, it is useful to think of the different intracranial volume compartments and their contribution. This table shows the different compartments of the intracranial volume and pathologic states that can result from changes in those volumes. For example, when we consider the intracranial volume of CSF, this will be increased in states of hydrocephalus or CSF-producing choroid plexus tumors. Additionally, idiopathic intracranial hypertension is related to elevated volumes of CSF, and this can also be seen in meningitis. When we think about the intracranial volume of blood, this can be seen to be increased in states of disrupted autoregulation, such as occur after head injury, or relative hyperemic states. This can also be seen with venous outflow obstruction and also in inflammatory states. When we think about the intracranial volume of the brain itself, this can be seen to be increased in states of cerebral edema, such as cytotoxic or vasogenic edema. And then there can be other intracranial volumes in the pathologic state, such as tumor, or hematoma, such as epidural or subdural hematoma, or intracranial hemorrhage. When we consider the effects of raised intracranial pressure, it is important to think of the cerebral perfusion pressure. Cerebral perfusion pressure is defined as the difference between mean arterial pressure and mean intracranial pressure. Elevations of intracranial pressure therefore reduce cerebral perfusion pressure, and this in turn can reduce cerebral blood flow if the limits of autoregulation are exceeded. A reduction in cerebral blood flow can result in reduced metabolism, and this in turn can therefore cause more tissue edema formation, which will then contribute to additional increases in intracranial pressure. Tissue swelling and raised intracranial pressure can cause brain tissue herniation, irreversible neurologic injury, and ultimately death. This is one of the pathways that can be seen to occur in so-called malignant or refractory elevations in ICP. It is known that in the healthy normal brain, cerebral blood flow is regulated across a range of blood pressures. This slide shows a graphic demonstrating autoregulation. The red line indicates normal healthy brain autoregulation, and it can be seen that across a wide range of cerebral perfusion pressure values, cerebral blood flow is relatively maintained. At much lower levels of cerebral perfusion pressure, or much higher levels, it can be seen that cerebral blood flow does start to change. The green line demonstrates a situation in which there would be no autoregulation in the brain, and in this scenario there is a linear relationship between cerebral perfusion pressure and cerebral blood flow. The purple line demonstrates what can be seen in a state of partially preserved or disturbed autoregulation, and in this setting the range of cerebral perfusion pressures over which cerebral blood flow is maintained is much narrower, and therefore the lower and upper limits of autoregulation are much closer together, and relatively smaller changes in cerebral perfusion pressure in this setting can result in altered cerebral blood flow. This has led to the concept of defining intracranial pressure indices. The difference between cerebral perfusion pressure and the limit of autoregulation is defined as the autoregulatory reserve. It is known that there is a relationship between the intracranial pressure waveform, the blood pressure waveform, compliance, and the autoregulatory reserve. Mathematical indices have been defined, such as the RAP index or the pressure reactivity index (PRX), which relate blood pressure and ICP waveforms. And these indices contain information about autoregulation and may ultimately be able to help guide management of intracranial pressure. Intracranial pressure treatment is important. Raised intracranial pressure is a major factor in 50% of all head injury mortalities. Mean intracranial pressure increases of 10 millimeters of mercury in the first 48 hours after injury have been associated with an adjusted odds ratio of 3.12 for mortality. Precise goals for intracranial pressure and cerebral perfusion pressure management have not yet been fully defined and likely depend upon specific patient variables. Current Brain Trauma Foundation guidelines suggest treating ICP above 22 millimeters of mercury and targeting cerebral perfusion pressure of 60 to 70 millimeters of mercury. However, the choice of treatment and these specific goals is dynamic and largely dependent upon each patient's specific physiology. When we think about ICP therapy, it is helpful to consider once again the different intracranial volumes. Changes in each of these intracranial volumes can be specifically targeted by the choice of therapy. This table outlines the different intracranial volumes, pathologic causes of change in those volumes, and associated treatment options that would target specifically that volume compartment. So, for example, considering the volume of intracranial CSF, this could be treated by ventriculostomy replacement or lumbar drain placement, or more permanently with a CSF shunt placement. Third ventriculostomy and acetazolamide also help reduce intracranial CSF volume. When we consider the intracranial blood compartment, this can be altered by disrupted autoregulation such as seen with head injury or inflammation. And this can be targeted specifically by hyperventilation or the head of bed position to maximize venous drainage. Loosening a cervical collar can also improve venous drainage. Specific goals of CPP management can help regulate the intracranial blood volume. And additionally, the use of sedatives or hypothermia by their effect on metabolism can also help reduce intracranial blood volume. When we consider the intracranial volume of brain tissue, which can be altered by edema formation, then treatment options that would target this include supporting tissue metabolism by appropriate oxygen delivery. Use of mannitol or hypertonic saline can specifically reduce tissue edema. Steroids will work in a similar fashion. And once again, as mentioned previously, the use of sedatives or hypothermia can also help reduce edema formation. When we consider the other causes of intracranial volume increase, such as tumor or hematoma, then surgical intervention becomes the primary mode of tackling this problem. Additionally, surgical intervention in the form of a decompressive craniectomy can specifically target any of these intracranial volumes by effectively changing the overall capacity of the intracranial compartment. However, when we consider intracranial pressure therapy, it is not always possible to directly treat the cause of ICP elevation. And in this setting, once again, considering the Monroe-Keeley doctrine provides a framework by which other treatment options can be utilized. So, for example, in the case of traumatic brain injury where there is diffuse swelling, additional CSF drainage by placement of ventriculostomy can help reduce the overall intracranial volume by targeting the CSF compartment, although the main pathology may be driven by the intracranial volume of brain tissue. Hyperventilation after traumatic brain injury can also help reduce intracranial pressure, largely by reducing intracranial blood volume. Similar effects are seen with the use of sedation. So in summary, The Monroe-Keeley doctrine provides a framework for understanding pathologic elevations in intracranial pressure. This same framework provides an understanding of different treatment options that may be available. However, there is a complex interplay between cerebral blood volume, cerebral blood flow, autoregulation, the mechanisms of edema formation, cerebrospinal fluid dynamics, and intracranial pressure levels that remain only partially understood. Treatments should largely be tailored to each patient's specific and individual physiology.